supported by USAID, and the project is there in these 6. So for the RMICHA strategy which was rolled out, different partners are supporting different, USAID being there in these 6 states, and this project is the other states which are there have been supported by NIPI, UNFPA, UNICEF and Tata Trust. So just a bit about our project. We are there in the National RMCHA unit, which was formed earlier for implementation and rollout of the RMCHA strategy. That's housed in our project, and through that we are looking at 184 HPDs across 30 states. We did the management of the National Supportive Supervision Mechanism and its rollout across all states. Coming to what's specific to the project, we are present in 6 states, 26 HPDs, and our major focus is around the care around birth strategy, and that's what I'll be talking about today mainly. Although there are other parts to the project which focus on the reproductive or the adolescent health part or some cross-cutting issues. So I'm just going to skip over that. So why did we think about care around birth? I'm sure this may have been talked about earlier. 46% of our maternal deaths and 40% of all stillbirths and neonatal deaths happen around birth, which is immediately the immediate postpartum period and the intrapartum. That's why the whole, what they say that the interventions that are focused at this period will have the maximum effect in terms of saving lives of mothers and newborns so what's the care around birth strategy? So the care around birth strategy for Vriddhi project, it basically has these 9 pillars. So adaptive learning, which meant that we looked at other examples of where people had worked around reducing maternal deaths, reducing neonatal deaths, saw what they were doing and learned from that. We did a comprehensive baseline across all the facilities that are there under our project, and we'll come to that a little later. Advocacy for implementation, another important pillar if you have to implement any project across the health system. We had a technical intervention package. I will take you through the 2 technical intervention packages and how we have broken it down into 2 phases. Experiential training, that being a major focus of the project. We've been training the staff of the labor rooms in the selected facilities. Structured mentoring visits to these intervention facilities. Quality improvement, a big major focus, and we have certain steps to it. Again, I'll take you through those. MIS, so MIS we've kept it in line with what already exists. We've not really created any separate mechanisms of MIS within, but what we are trying to do is improve the quality of data that they are recording, especially in the labor room registers, in the HMIS that they are doing, and using that we are feeding into the project work, and also looking at the impact. So talking of the technical intervention package, we've divided into 2 packages, tip 1 and tip 2. First package here, if we see, the package 1 basically deals with the interventions which are universal, that will be required in any delivery, and package 2 deals with special cases where you have management of complications. So if we look at the package 1, we did monitoring of labor using Partograph. We focused on Amstel. We focused on postnatal vital monitoring. And for the newborn, we had preparedness before birth, essential newborn care and resuscitation, newborn vaccination. This is what we took in technical intervention package 1. Package 2, which is yet to be rolled out, would consist of PPH management, preeclampsia, sepsis management for the mother. For the baby, we'll have care of low birth weight babies, antenatal corticosteroids, and management of newborn sepsis. This is going to be part of for both tip 1 and tip 2, we have components which are for system strengthening, wherein we are looking at labor room management, we are looking at the documentation, improving that. So for tip 1, we had handing over, taking over, shifting of duties as a major, inventory management, infection control practice. Then respectful maternity care is also something which is not really there in the current modules that we have from GOI, and that's a new component that we added to the training package. And that deals with things like privacy, informed consent, equality and equity. We've done in tip 1, we focused on it. Tip 2, we'll work more towards strengthening this component. Quality improvement, just like to touch on what the project is doing. So we have QI teams at the facility level, the low dose high frequency mentoring visits by the district technical officers. We have Lydia here. So she's also a district technical officer. So we have one person from the project in each of the HMs. We have on-site visit by specialists, gynecologists and pediatricians who would then help the staff in management of complications. We have these experience sharing platforms wherein the different QI teams come together. They share what they have been doing in their facility, how they've managed to make any improvement or they've not managed to do the improvement, reasons for that. So we have an experience sharing platform, and we look at local champions to identify staff members who are doing well, acknowledging their work. So all that is part of the QI efforts that we are doing along with the health facility. Coming to Haryana, we have 5 HPDs and we are working across Jeend, Hisar, Panipat. Just a bit on the structure of the project team. We have a state level team and the state technical team lead for Haryana. We have state technical officers. I have my colleagues here, Dr. Asif and Dr. Shailendra. And then each of the districts, 5 districts, we have 1 district technical officer. In Haryana, we have selected 31 facilities. Each district has 6, except Palwal, which has 7. If we look at the kind of facilities that have been selected, we have 5 district hospitals, 2 STH, and the remaining are CHC. We have 13 and few PH. These were selected just on the basis of the number of deliveries or the delivery load that we have. And what we see is that we have selected 19% of the facilities in these 5 districts cater to 66% of the deliveries. These are the high case load facilities that we have. This one is just to give you a rough idea of what is the delivery load. So the long bars are so if we see the variation is Mewat, it's 184. Panipat, which has an average of 650 deliveries per month. Within district also, there are a lot of variation in terms of the delivery load of different levels of. So, since we've been, I guess, 4 days talking of health systems and the health system, I'm sure this slide would have come up a lot. What I've done is I've structured my presentation according to few of the health system plots, kind of understand how we did, what we did, and whether we had success, what were the challenges that we faced as we went. I would not be really covering all of them, but whatever is relevant to the project. So leadership and governance, if we talk of, so the project felt it's really important to have the government on board. Since the project is just a technical assistance, we are not bringing any additional staff to the health system, existing health system. We are not bringing any additional money in terms of if they need medicines or equipment, but we are there as facilitators, facilitate the whole process of improving things that are already. So advocacy at the state level, we had the state continuous dialogue with the state program managers, the mission director. That's a very important component. State orientation, we had this orientation on the CAP strategy, and this was followed by the district level advocacy and dialogue with the district health authority. District orientation was also held in each of the 5 districts. Here we have our civil surgeon from Palwal. What are the challenges that we face if we talk of leadership and governance? Haryana in the last 1.5 years has faced multiple changes in terms of leadership. We've had changes of our mission director at least 4 times, our ACS as well. So every time a new person comes, it's a new start for us in terms of doing the advocacy, making them understand the kind of work we do, what we are trying to achieve by doing this. That's always a challenge. Then interdepartmental coordination, we have different units. So you have the DGHs, you have the NHM, you have your medicines and all are dealt by the corporation. You have HSRC who is doing certain different components. Within that, coordinating with each one of them on different components. What we are trying to do is actually help the health system strengthen in terms of delivering the service. So a lot of time it's cross-cutting things where we have to touch point with different leaders within the organizations in the government. That's always a little challenging. And also changing priorities. So we are in the midst of doing CAB, and that's the most important thing for us. But for the government, it's the mission Indradhanush which is important. Changing priorities of health system also, which kind of affect what you are trying to do. Health financing is something that I'm not really going to touch, but just wanted to show you one slide. So this is also, since it's actually external to the project, but important from the health system's point of view. Then I'm picking up the block of medical products, vaccines and technologies. So all my talk would be in the context of the labor room where we are working. So like I said, we had done a baseline assessment of these 31 facilities across 5 districts, and just picking up a few examples of where the gap. So here it gives the number of facilities with different support amenities and ancillary services. Few which I think are really critical, especially when we talk of 48-hour stay or we talk of services fall from the client's perspective. 23 out of running water, 28 had, 3 did not even have running water, 24/7. Drinking water only 23 had. Electricity 24/7, 20. Now this doesn't actually look bad when you look at, by definition it's come to 23, but when you look at actual what the dietary thing is, so under GSSK there's just been provided some food. So whatever is the amount, it could be just milk for that or ghee given for that or almonds given for that amount. So it's not really food which patient could actually consume and be there. So they are still dependent on their relatives, on their families to get food. Though it is 23, it's still different. If we look at the lab tests, the blue one bars above are the presence, whether they are available, and 20, the yellowish bars are the ones that they are present 24/7. It's like HIV screening, MP blood grouping. In these 31 facilities, and these are high case, includes your 9 FRUs also. So if you consider 9 also, we just have HIV, we just have 7. For the L3 facilities, out of 7, 6 had ultrasound available and only 1 has it in-house. So even for the other 5, it's a tie-up with somebody outside in the private sector. Always has its challenges in terms of not being really smooth in terms of services being availed by the looking at things like delivery tray in the health facility. Out of the 6 facilities, this is the gap. 4 really did not, 4 had deliveries trays, 2 did not have. So this is, we are talking of designated delivery tray, that this is the delivery tray can be used, so 2 did not have. So this gap you can see here. And out of the 31 assessed, only 2 facilities had all the individual items. So this is the list of all items that are required. Actually, so if it's a delivery that's happening and they need those things, if they are not there in one place, it compromises the quality of care that we are going to provide to the woman. Talking of stockouts, oxytocin, we had 5 facilities with stockout. Maxal, again 3 facilities. So these are critical drugs that, and actually no stockouts are active. Medical equipment for newborn care, 31 is the total number of facilities, and you can see the gap that is there for things that are there. None of the assessed facilities had all the medical equipment, and here the basis that we have taken is the MNH toolkit, which is by GUI. So in our project we are sticking to the MNH toolkit, sticking to the training guidelines that have been given by GUI, and there is no other external thing that or standards that we are applying. Here you see Palwal, out of 7 facilities only 2 had it, and this is gap that we see for individual items in the newborn. Been there since 2014. Still only half. Health system block that I'm going to pick up is the health work. So here is the FRUs that are there in the 5 HPDs that we are talking about. Out of the 9 FRUs, only 3 are actually. FRU by definition needs to have a blood bank, needs gynecologist, anesthetist, a pediatrician. Although we've included Panipat in a functional FRU, if you look at, they have a blood bank by Red Cross, which is why blood really doesn't. The only thing is that we do have C2. If we see Hisar, Jind and Panipat out of 5, which have 1, and 2 districts did not have even 1 facility. Now this is a little complicated. I'll just tell you what it's trying to show here. So we looked at the number of staff nurses who are posted in the facility, number that are required as per the MNH toolkit based on the delivery load that they have, and we looked at the short. So red is less than recommended, green is that's absolutely alright, same number of staff as the required, and we have here orange, which are where they have additional staff. So this is example of Palwal. Other than the general hospitals, there is shortage of staff everywhere. There's a surplus in some places and there's a shortfall in the others. However, you all who've been working in the health systems know moving this surplus to where it's actually required can be a great challenge. There are different reasons for it, and I'm sure. In our baseline, we also did the assessment of the health staff nurses who were there. So that was done for 83 staff nurses across 5. It's the competency assessment, And just to give you a glimpse of how the staff nurses were performing. So on partograph, it ranged between 4.5 to 6. If you look at active management of third stage of labor and the knowledge assess, they were doing a little better. Out of 10, we had a score ranging between 7 to. So the competency assessment that we did in the baseline became the basis for our training that we did later on. So we have had the phase of the technical intervention package 1 trainings across all the 5. 31 facilities we had 231 staff nurses. In the first round we did district level trainings. It was a 2-day training covering 10 modules. In that we covered 75. So we just did 1 workshop each. For the leftover staff nurses whom we could not train in the district level workshop, we had facility level. It was based on the principle of low dose high frequency training, wherein the 10 modules that we covered in 2 days, we divided them into 4 rounds. Every month we used to have 1 round and train the staff nurses. So through these facility level trainings, we've been able to train 107 staff nurses and 87 facility level. We have a system of name based following up each of the staff nurses on the number of modules that they have covered. So as you see the lower part of the bar, 75 are the ones who completed all 10 modules in the district, and then the orange parts are the ones who in the facility level. That's the gap from the 231s. And we've reached a level of 80%, and that was the objective that we had kept for our project, that we'll train 80% of the staff. For the others, we expect a spill effect will happen. As the ones who have trained, they change their practices, the others will learn. Quality improvement again is an important part of our project. We've made quality improvement teams in all the 31 facilities that we are there. So the teams consist of medical officer in charge, anybody who is there in the hospital who is directly or indirectly related with care provision in the labor room. So the role of the district technical officer from the project side is just facilitatory in terms of ensuring that the QI teams meet and they discuss the issues that they have. This is what we are following up, the information that we collect, which is when was the meeting held, participants, key discussions, what is the aim that the team selects for change. Here we look, they said that the LR management during handing over and taking over, they wanted to improve that, and for that they said that they will use, what would they do? They would use the infection prevention checklist and handing over and taking over. They follow the red signal, light signal system of cards, and they've given themselves a timeline and the responsibility of, we've just written staff nurse here, but within their own register they would specify who is the staff nurse who would be responsible in ensuring that this happens. This is the red light system that I'm talking about. It's a little blurred. So what they do is that the aim that they have chosen, they put it on a red card in their nurses station. So here it said that oxytocin is not being given, the first one was that fresh stillbirth and macerating stillbirths are not being identified. That they put as a aim. When they start doing it, yellow, so they say that we have started identifying. And when they are satisfied that they are not missing cases, this is what they put a green one saying now 100% of your fresh stillbirth, macerated stillbirth we are recording. Done by the staff nurses themselves in their area, which means their nurses station where they spend time. The whole concept of them being in control of the change that they want to do. So they only select the change idea and they only work on it. Some stories of change that we have seen based on different things. So it is an outcome of the training, an outcome of the QI teams, outcome of the mentoring visits that the district. That's where we are now seeing certain little changes that are happening. So as part of our infection prevention and tip 1 training, we had taken up chlorine preparation and its use as a major thing. And this team in CHC Barwala, they worked on that. Task force would make it, nobody knew कि कितना chlorine डाल रहा है, कितना पानी डाल रहा है, कहाँ रखा है. Different areas of the hospital will make it separately. Not really sure what's the concentration of chlorine and how it's being. After the training, they decided to work on it. They now prepare, they've calculated in 1 day what's the chlorine amount, volume that they required. For that volume, how much is the chlorine that would be required. They have a container marked so that the sweeper knows that this is the amount of chlorine, exactly how much I need every day, and this is the mark on the drum till where I need to fill the water. And they've prepared this. This is a special drum. We fixed a tap here, right here, a little above the base so that the chlorine settles down, and what they get is actually clear chlorine. Another example is from Mewat. They had an issue of not really using their photographs well. So that is what they focused on. and the intervention included advocacy on the importance of its use as well as capacity building of staff. This is the improvement that we've seen. Zero from January to April. May, June is the time when we started went up to 40%, and gradually now it's gone up partograph. For this we are checking the case sheets that they have, and here if we look at the proportion of deliveries for which it was filled was right from February earlier on when the completeness was zero. The proportion of deliveries is showing 100%. So it was being filled for everybody, but not really properly, not being used. That's what we have been able to do, improve the use of newborn vaccine. BCG, which was going along with the other two, fall in. This is because the staff nurse who was posted there for specifically doing this work got transferred out, so your BCG vaccination immediately fell down. Then this is here where district technical officer made sure that he got everyone together to talk about it, what is the issue, how we could resolve it. They decided to have an AMM assigned. Definitely requires some more work. Looking at completely filled partograph, this as you see is gradually, our trainings have been between this period. Average number of times the mother were monitored 6 hours post delivery. Mewat and Palwal are still here. And the major difference being in terms of the availability of the staff. So if there are fewer staff, more delivery load, have this indicator of identification, we are nearly going to stable at 3 to 4%. And the other indicator was of successfully resuscitated. And that seems to be picking up after the training that has. Newborn vaccination for all 3 vaccines. Most districts are doing well, majorly because of BCG not being given. And why BCG is not being given, it's either the staff nurses don't know how to give it, or there's shortage of the BCG syringes which are being used for other purposes as well. The number of times mothers were monitored, as you see, after our trainings here from May onwards, this has picked up from 3.9. This is the number of facilities who are monitoring mothers at discharge. May was just at 7, has now increased to 16, but we still have a gap of percentage case sheets where BP, pulse and temperature was monitored at the time of discharge for the mothers. Case sheet verification for postnatal monitoring. This is for the newborns. The percentage of facilities who are monitored within 1 hour, that remains stable. But within 1 to 6 hours, that has shown an increase from 19%. So, though the number of facilities who are monitoring seems to be same, again, it's again an issue of HR, where if you have less staff nurses, more deliveries, it becomes difficult. 1 to 6 hours, the percentage facilities where monitoring of newborn done at the time of discharge, this has shown. So, these are basically few of the indicators that I wanted to share in terms of showing you what has been the outcome of working at in the health high priority districts and how it gradually picking up. So as part of the project, our technical intervention package 2 would be starting sometime in late December, early January, where we then work on the management of complications. So whatever improvements we've seen here, I'm sure you would have seen that slide on systems thinking, where you have people in the center and all your health blocks around. I'd like to emphasize here that people, whether it's the staff nurses, whether it's who works really hard at the district level, at the state level, how to make things easier for the people, whether it's clients or the provider. At the same time, the health blocks are not really separate things. They talk to each other, they interact with each other. Dynamics are so different in each, so one needs to really look into different aspects.